Hi guys, welcome back to another video from the Aspiring Medics. As always, I'm Dr. Yusuf and I'm joined by a guest. Would you like to introduce yourself?
Hi, I'm Sophie. I'm a Cambridge medical student.
Excellent. And in today's video, we're going to be going through a Cambridge mock interview. And from your guys' feedback from the last video, you guys wanted a harder interview. So no more Mr. Nice Guy. So this one's going to be more in hard mode. And again, this is going to be quite intensive. So it's going to be a 40-minute video that we're aiming for. It's going to be quite intensive to go through the questions that you can get in a Cambridge interview. So without further ado, let's get into it. Okay, so as part of the NHS 10-year plan, do you think hospitals should be ranked by league tables?
Okay, so first off, we need to address what actually are we ranking the hospitals by, because there's also different things you could rank hospitals by, and a lot of these things won't be very relevant to patients, and I don't think would really matter when it comes to patient outcomes. So for example, if we're ranking them by patient success, and how are we even ranking that patient success compared to ranking them by more financial incentives, a patient's not going to care about their financial incentives. And then overall, I think ranking hospitals already, for example, it could potentially have some benefits, with more accountability for hospitals that are maybe not doing things correctly, and also could give us some ideas about which hospitals need perhaps more attention or more resource allocation. However, I think the cons of this more outweigh it, because ranking things in ways like this is definitely always going to be a bit of an oversimplification. You're never going to really understand what's actually going on in the hospital, or really unless you actually properly look into each individual hospital rather than giving them a rank. And ranking systems like this may also lead to different hospital trusts trying to game the system to get a better rank, and that can lead to shortcomings in other departments. And if staff are focused on statistics, they may be less focused on delivering great patient care, and it can change the priorities of the staff to focus on upgrading the hospital's rank rather than providing the best care, and that's not really what we're trying to be doing. So it could have its uses if it's done well, but if it's not designed well, it could penalize hospitals for the wrong things and overall damage patient care.
What about if, as per West Streeting, it's done to empower patients to be able to make an informed choice when it comes down to hospital selection?
Yeah, so there's two ways we can look at this. In for example, an emergency case, how the hospital's rank isn't going to really matter when someone's, for example, having a heart attack and they urgently need to go to a hospital. And if they're then seeing that the closest hospital is, for example, a lower rank than something 10 minutes away, will that cause them to then go to a further away hospital? And that could impact their care way more than a hospital a couple ranks below. And then also with perhaps more long-term care things, or less urgent things, having all patients directed to one hospital that's perhaps ranked higher could lead to disproportionate patient numbers in hospitals, and leading to certain hospitals being more overwhelmed than others. And that's going to stretch resources thin as well, if all the patients are going to be concentrated at certain hospitals.
Yeah, exactly. And that in itself could result in a pendulum effect as well, right? Where the good hospitals are then overcrowded and then go down.
Yeah.
Exactly.
And it's not very accurate representation of anything that's actually going on.
Interesting. Okay, thank you. So next question. Whistleblowing protects patient safety but brings about ethical and professional risks. What ethical issues arise? What barriers might NHS staff face when raising concerns?
Yeah, so whistleblowing is when someone, NHS staff, part of or any staff really in any context, reports something that they think is wrong to a higher authority, and it's usually about somebody else on the staff, and if they've seen something wrong, or even if it's just an accident. And there's lots of barriers that may determine if someone actually does whistleblow on something. For example, it can really damage your relationship with your co-workers if you don't want to be whistleblowing the people you're constantly working with, because that can then damage those professional relationships and lead to you being a bit isolated. The process of whistleblowing as well, it's quite a complex process to report things that are going wrong, and that can lead to a lot of emotional and mental stress as well. And that could perhaps, in an ethical dilemma, impact your ability to give care if you're constantly worrying about things you think being whistleblown on, or about another co-worker you've whistleblown on. And also, you want to think about confidentiality as well, because if you whistleblow something, that could threaten the patient's confidentiality if it's something about them, and it could also threaten the confidentiality of your co-workers and things like that. And then also, I think a big concern might be the protection of whistleblowers within the NHS. That's quite a bit of a hot topic right now as well, with whistleblowers not getting the protection they need and then being at risk of things, being at risk of like receiving backlash from their co-workers and everything. So there's a lot of things to consider and a lot of reasons why someone might not want to whistleblow. And I think it's very important to foster that like speaking up culture within the NHS, since patient safety should be the #1 priority. And if you're worried about whistleblowing something that threatens patient safety because of backlash, that shouldn't be what you're worrying about. You should be worrying about, reporting things and making sure things are going well.
So what can be done to create more of a culture of transparency and whistleblowing?
So to create more of a culture of transparency whistleblowing, I think offering proper protection for whistleblowers would be very important. Offering confidentiality for them as well. I think creating really proper like pathways people can go down for whistleblowing, so it's less of a thing, it's less of like an unclear pathway, and making it very easy for someone to whistleblow, and then also perhaps have that protection from people they have done. And then I think also more legal protection for whistleblowers as well would be very important, and making sure that they feel like they can, and then also perhaps providing some mental support as well, because it can be quite emotionally stressful.
Great, that's very helpful. Thanks so much. So I'd like you to have a look at this graph. How does socioeconomic status affect cardiovascular risk? And first off, by just describing the graph that you see in front of you.
Okay, so this is a graph that has split all the patient participants into a high affluence, medium affluence, and low affluence group. So like by socioeconomic status, and then on the left side, on the y-axis, they've done it by percentage, and on the x-axis is like different groups. So the percentage of people in each group with like diabetes, hypertension, obesity, and then also who undergo certain like lifestyle things such as not exercising, smoking, and then you can also see that they've split them into 3 groups. And I guess to describe the graph, you can overall see a trend that as you in most cases, as the socioeconomic factors decrease, you get like more of an increase in, for example, obesity, in like the pathologies, and also in the risk factors such as not exercising and smoking. However, you can also see the error bars are quite wide. So I don't know if it's really a study that you should draw all your knowledge from, since there's quite a lot of overlap in these, and it might not be entirely reliable. We also don't know a lot about the data.
Good. So what's your overall headline? What's it showing?
It is showing that well, I think overall it is giving an indication that lower socioeconomic risk may increase cardiovascular risk, but that we don't have, this graph isn't showing definitive proof, I think.
What is this specific graph showing?
It's showing that with lower socioeconomic risks, you might have an increase in for like cardiovascular risk for diseases that are associated with cardiovascular risk, such as diabetes, hypertension. And then also you're more likely to experience things that increase cardiovascular risk, such as smoking, not eating as well, so that's the less servings of fruit and vegetables, and not exercising.
Yeah, so you've already mentioned these lines as being error bars. What do error bars mean?
Error bars mean that the data is like the data that they've shown is an average, and that this is kind of like the standard deviation of the data, I'm pretty sure. And so like the data kind of falls within this range.
So there are multiple ways. It could be standard error of means, it could be standard deviation as well. But in general, error bar is looking at where the true average of the data set, mean average of the data set lies. It's saying usually with 95% certainty that the true mean average lies within the data bars. And as you've outlined, the data bars are really wide that you can see here, or really tall that you can see here. And in general, would you say that they overlap, don't overlap, 50%?
Yeah, they
overlap,
definitely overlap. 50%. Yeah, some of them are like in between the others. So
what does that mean then?
That could mean that the data isn't conclusive to show that socioeconomic risk status is a risk factor, since the error bars are overlapping. It shows that there might not be a trend, because, for example, some of them could end up being higher than the others, or you could end up with like the opposite effect.
Yeah. So whilst on first glance, as you say, it looks like for low affluent, medium affluent specifically, or definitely high affluence versus low, the bar that you can see does look higher for low affluence, i.e. a higher risk, quote unquote. You can see that actually the error bars have a massive variation, and that actually, based on this data alone, there isn't a statistically significant difference across affluence. Now, how does that compare to what your previous understanding is?
It is like this data does suggest it might not be, which is kind of different from what I presumed, but it is only one study, so there might be more data. Like with this study, it isn't conclusive, but there might be more data that suggests it is. I think you can't take anything from just one study. I think it shows that you need to have a look at multiple things.
So what questions do you have that you'd want to ask to the study authors, for example, about this?
Well, I'd want to ask why the error bars are so wide, and that could be how many patients are in. How many patients are in the study? What is the patient population? What were was this how did you randomize the study in a way? How did you collect the data? What were the the potential confounding factors in this data? And were all the groups equal is very important as well. And what other things controlled for? Because socioeconomic status is what they're testing. However, there could be lots of other factors, like, for example, some of these patients with lower socioeconomic status could live very near, for example, a factory, and that could affect things like bad like air quality could affect other things, or they could be live in a certain area with less access to with less access to gyms, and that could be something that's less directly correlated with, while it is like a correlator with socioeconomic status, it's not directly because of the socioeconomic status that they are less likely to do certain things.
Yeah, so there's multiple things, right? So it's affluence. How is affluence defined? Is that by household income? Is that based on your postcode, based on your area? Is that based on the country that you're from, for example? So there's loads of questions on that. The y-axis naughtily isn't really labeled, so we're assuming,
it's just percentage.
So we're assuming that that's percentage in terms of proportion of people, for example, that might have cardiovascular disease, that also have diabetes, hypertension, but it's really not clear in terms of actually what that means. Actually, what would be really interesting to know is something called relative risk or absolute risk. What's your understanding of those terms?
I haven't had those terms before, but I guess relative risk would be more like how the risk factor, I guess, for I don't know, maybe absolute risk would be the normal I don't know, explain this very well, the normal amount of risk. I'm not sure.
That's okay. So it's really thinking about proportion and probability, right? So actually thinking about, one, we're not looking at really causative data, because we can't really randomize people to say smoke, don't smoke, or it's all based on lifestyle factors. We're looking at correlational data. We're looking at how closely associated certain data is. So an absolute risk could be saying, for example, that being in a lower socioeconomic background puts you at 2x risk, 2 times risk of cardiovascular disease, for example. That's an absolute, because that's 2x, 3x, half, for example. Whereas when you're looking at an absolute risk, that would be 30%, 40%, 10% higher chance, for example. Does that make sense?
Yeah, that does. Yeah.
So those are both things that we can use, and then those become both things that are very useful to know, especially when you're then comparing it to a healthy population. All right.
Yeah.
So we'll move on from here. How would you explain to a patient the importance of taking their blood pressure medication regularly in a reassuring, simple way that avoids causing fear?
Okay, so first off, I would make sure the patient, for example, understands what they're taking the blood pressure medication for and why that is important. So like you could explain this by you, for example, using analogies, or also like explaining to the patient that taking blood pressure medication is nothing to be ashamed of, because that also could be a reason, and making sure they know that a lot of people take blood pressure medication for a variety of reasons, and then like go into the detail of why this is why you take it. For example, they could just have they could have something like high cholesterol, and that may be a reason why they're taking, which is causing them to have high blood pressure. So they could be taking blood pressure medication for that, and then explaining in a like non-judgmental but like non-fear-provoking way, like, oh, so this is why you take the blood pressure medication. This is what it actually does to benefit you, and then this is what happens when you don't take the medication. But I think it's really important to be really careful when you talk about this, because I think creating like a sense of fear around the medication could cause someone to go the opposite way and just not take it at all. And then I think it's important to also just explore the reasons why they might not take it, and then explore that with the patient as well and discuss that. So, if perhaps a main concern for them is like forgetting their medication, work with them with ways which will help them remember to take their medication. And then I think
what could that be?
So that could be, for example, using those like pill cabinet things. It could be
Yeah,
reminders on the it could be reminders on their phone. It could be letting a family member know to tell them to take their medication. It could be creating a routine. It like for some people, having a routine in the morning, which includes taking their medication, is a great way to like make sure that's regular.
Fantastic.
Yeah.
And so summarizing, what are the main reasons to why someone might not take their blood pressure medications regularly?
So I think one reason might just be forgetfulness. Another reason might be like misunderstanding what the medication's for. So they might just like not understand why they need to take it, or not understand like the benefits of it. So they just don't want to take it. It could be a distrust in like medical professionals in general, and so they don't really want to take the medication because they don't feel like they can trust it. And it could just be them not liking the method of taking it. So it could be more of a medical issue that they're not able to swallow, and then you need to work with the patient to find a different way they can take the medication, because they might not have communicated that originally.
Fantastic. So we'll move on now. So now moving on to the heart. So we were talking about blood pressure medications. Suggest why a left ventricular wall needs to be thicker than the right hand side.
Okay, so the right side of the heart, like the right ventricle, they pump blood to the pulmonary circulation, so to the lungs, whilst the left side of the heart pumps blood to systemic circulation, so through the aorta to the rest of the body. And pulmonary circulation is just to the lungs and back to the heart, so it is a lot smaller than systemic circulation, which goes through the aorta and then up to like the head, and then also down to the rest of the body. So that's quite a bigger area, and there's a much larger resistance to flow in systemic circulation than the pulmonary circulation. So you need much larger forces to pump, which means the muscle needs to be thicker, so you can generate larger forces. So you can generate those larger stroke volumes to pump to the rest of the body.
Excellent, well done. And I'd like you to have a look at this graph. Firstly, just describe what the graph shows.
Okay, so on the bottom is showing like work rate in watts. So as we go from left to right, we increase the work rate. So this could represent like an increase in like exercise intensity, for example. And then there's 3 different lines, and they each have their own like thing. So I think to focus on the main one, as we increase the work rate, we increase the cardiac output. And cardiac output is how much blood we are delivering to the tissues, that for mainly the muscles, for instance, that need to be oxygenated. So as we increase the work rate, we're increasing cardiac output. And then we have 2 other lines. We have heart rate and stroke volume, which are the determinators of cardiac output. So if we look at heart rate first, as we increase the work rate, for most of the time.
What is heart rate? Not a trick question. What is heart rate?
Heart rate is how fast your heart beats. So it's how many beats per.
Yeah, good. And what is stroke volume?
Stroke volume is the volume of blood that is like ejected from the heart per beat, like so from the left ventricle into the aorta.
Good. And what's cardiac output? Sorry.
Cardiac output is the volume of blood that is ejected from the heart per minute.
Great, fantastic. Sorry, carry on.
So yeah, if we go back to stroke, if we go back to heart rate, as we increase the work rate, heart rate is increasing because this is like your body's compensatory mechanism to increase the amount of blood that is pumping towards the body by increasing the amount of pumping of the heart. And then with stroke volume initially increases, and this could be due to like well, obviously when we exercise, we have like sympathetic stimulation and also the release of adrenaline, and those will have effects on the heart to make these changes. So they try to increase the stroke volume by making the heart contract more or contract harder to pump more blood away. However, as we get to like 100 watts, the stroke volume begins to like plateau and decrease. And I think one of the reasons this could be is we simply just don't have like enough like blood returning to the heart to pump. So because obviously the blood has to reach the rest of the body and return to the heart, and then return to the heart. And so if we can pump harder and harder, but if there's not enough blood to pump, you're not going to pump anything, or you're going to not have enough to pump to the rest of the body.
What do you mean what's happening to the blood? It's still in the body, it's still in the heart, isn't it?
Well, yeah, it's just yeah,
out.
it's like,
where's it going?
Yeah, no, it's not being pumped. It's not returning to the heart quick enough. Like
Why?
Because blood, it takes time for blood to travel around the body, because it's like the veins and just all the blood vessels have a resistance. So there is a resistance to flow. So if blood is not returning to the heart fast enough, it's not returning from the veins to the heart, then it's not going to be able to, like, the ventricles won't be filling as much. So when you go into diastole, it's not going to pump out as much.
Yes. So you're saying that it takes a while for it to go from the body back into the heart. Specifically, what part is really important for stroke volume? What part of the heart do you think?
The ventricular wall.
Yeah. And how do the ventricles get filled?
The ventricles are filled from the atrium. When the atrium contracts and it fills the ventricle.
Yeah, exactly. So you've got atrial filling that happens, and that can be one of the limiting factors as well to ensure that it's actually able to sort of travel down into the ventricles. So yes, absolutely. And also from the body as well. Absolutely. So that's very good. Excellent. Anything else you'd like to comment on in terms of trends?
Well, I guess there's even though the cardiac output is determined by the heart rate and the stroke volume. And so even when the stroke volume decreases, you can still see an increase in cardiac output. So I guess that's just showing that the heart rate is still, the increase in heart rate is enough to offset the decrease in stroke volume.
Good. So that leads me on to my next question then, which is then carrying on these graphs, firstly with stroke volume. What's going to happen to stroke volume if we carried on a line?
Well, stroke volume will just keep going down, most likely.
Just down straight line? Will it be curved?
It'll probably be a bit curved, because perhaps I think it would be a bit curved. It wouldn't just straight down, because you would get less blood return to the heart.
So would it be going down with a steeper gradient or less steep gradient?
I would assume maybe less steep, because I guess you'd still get a little bit of blood pumping out of the heart.
Okay.
I think.
And heart rate?
Well, I think heart rate at some point is going to reach a maximum. There's a maximum heart rate. There is at some point you can't just keep stimulating the heart, because the action potentials are going to catch up to each other. So I think here you can also see it's already decreasing a little. So I think it would decrease a little bit and then just plateau.
Okay. And cardiac output? Is it going to continue to rise?
I don't think it would continue to rise, because the stroke volume is still decreasing, and you're going to reach a maximum heart rate at some point. So once the heart rate kind of hits its maximum, the cardiac output is going to
heart rate.
Yeah, so the cardiac output will begin to decrease.
Fine. Where is the maximum heart rate?
It's between the 550 and 200. So I'd say about 175 watts.
Yeah, exactly. So it's about there. So it's literally just at that point there where you can literally just draw that line. So you can already see the heart rate's really peaked compared to the work rate there. And therefore, going by what you've said, absolutely, you can see that even though stroke volume's decreased, heart rate has continued to go up, which has enabled cardiac output to so far continue to increase, but you can see already
it's kind of reaching that top,
beginning to level out. And then given that heart rate stroke volumes have been going down and cardiac output equals heart rate times stroke volume, it is also going to go down at the same rate, basically. Does that make sense?
Yeah.
Great. Okay. And describe what this patient data might indicate.
Okay, so there's a lot of data here. If we go each order, the heart rate of the patient is 112, which is a lot above the normal value. So patient is tachycardic, heart rate is very fast. And that could be a compensatory mechanism for a lot of things, particularly just the tissue's not getting enough oxygen. And then blood pressure is low. So yeah, blood pressure is low. That could be because of multiple things. It could be because the heart is not able to pump blood like at a high enough pressure. So that could indicate something wrong with the heart, because it's not like usually when blood pressure would be it would like increase compensatory, but here it's low. And then stroke volume's also low. So that, I think, along with the low blood pressure, suggests something is wrong with the heart's pumping mechanism. If the stroke volume's low, and that would particularly be the pumping mechanism of the left ventricle, or both ventricles, is not being able to pump enough blood from the ventricle into the aorta. And cardiac output is also low. So the cardiac output's low because stroke volume is low, despite heart rate being high. But I guess stroke volume is having a larger effect than heart rate, potentially. So I think stroke volume times heart rate is cardiac output. So cardiac output being low suggests that the increase in heart rate is perhaps a compensatory mechanism, but it's not working. Potentially. And then ejection fraction, I'm pretty sure, is the amount of blood that goes through the valves when there is a contraction. And so
it's the proportion of the blood that's basically squeezed out, basically, in the ventricles.
So usually
it's like an efficiency perspective.
So usually it's a lot more efficient. So it being less efficient suggests an issue with the valves. So that could be something like stenosis, stopping them from like.
What's that?
Stenosis is valve stenosis is basically when the valves aren't working properly. It means they can't like open or close properly, and so you get like a reduced like perfusion of blood like through. I'm pretty sure.
So we've used the big word. Now I'm a simple man, all right? So if we imagine valves as simply opening, closing, closing, you can imagine that valves are effectively like doors. And as we've said, doors open, doors close. Now, what happens when a door isn't able to close properly, or when a valve isn't able to close properly? Not true.
You get a bit of leakage.
Yeah, and do you know what that's called? I don't expect you to.
Depends which way, I guess. If it's going the opposite way, would that be like regurgitation?
Yeah, exactly. It's regurgitation, basically, when it's going in the opposite way. So that's when the valves aren't able to basically, so that's one thing that can definitely cause it. What's the other one? So sometimes you might get it where they're also, so I say, not able to close properly. So you get this regurgitation where you've got this backflow. What's the other thing that sometimes can happen with doors? They close and they also
open.
Yeah.
Stay open.
Yeah, exactly. So if they're not able to fully open up, for example,
they'd be narrowed.
Exactly, they'd be narrowed, and that's what we call stenosis. So you can think about it either way. So like a door, if it's not shutting properly, if it's not closing properly, both things can cause problems. And the function of a door is to both open and to close. Does that make sense?
Yeah.
Great. Okay, so now moving on to this graph. What does this graph show you?
Okay, so this graph is showing the relationship between ventricular and the volume, so ventricular and diastolic volume. So that's like the volume after the ventricle has contracted, or like how much it's stretched. Myocardial stretch. Ventricular and diastolic volume is like, I think the stretch after it's contracted, I think.
So it's the filling part. It's when the ventricles sort of fill up.
Okay. Oh, okay. Part. So how much it's stretched when it fills. Okay. Yeah. That makes more sense. And then ventricular performance. I guess it's just like the intensity of the exercise that's going on.
Yeah,
like the
exactly.
intensity of activity.
And what do we know to be ventricular performance? We've said so many things, but what can be as a proxy for ventricular
Like
performance?
cardiac output or
Cardiac
stroke volume.
output, stroke volume, ejection fraction, stroke volume, ejection fraction. Those are both things that we can consider to be ventricular performance, really. Good.
Yeah, and then so there's multiple things on here. So the normal one in orange, it shifts to the left in exercise, which would mean, so I think suggests like during exercise, the myocardial contractility increases, which I think makes sense because you would want the ventricles to fill more in exercise, so then you could pump out more and increase your stroke volume. That makes sense. And then you have the heart failure line, and that's a lot lower. And I think that's probably suggests that because in heart failure you get hypertrophy, which is like the thickening of the muscle.
What is
of the
heart failure?
Heart failure is basically when the heart fails to pump blood to the rest of the body, so you get like the tissues don't get enough oxygen, so they get like hypoxia, and so the heart tries to compensate for that by increasing, like thickening the walls of the ventricle to pump more. But that
yeah, exactly. So it's when the heart isn't able to pump blood properly through the body, which can result in a build-up of fluid, either in the body, in the legs, or, for example, in the lungs as well.
Edema.
So you can, edema, exactly. So you can broadly consider it to be fluid swelling that you can get in the body, in the peripheries, or in the lungs. That's an oversimplification, but it works for the purpose of this video. And what does myocardial mean? That's another big word.
Myocardial, so myo is like muscle, and I know cardial is heart, so just heart muscle.
Good. And what's contractility?
I think contractility is just like how forceful it's able to contract, I think.
Exactly. It's kind of exactly that, how forceful it can contract within the same sort of muscle volume units, for want of better words. You can sort of consider that as being. And you were saying, so why does it in your mind make sense for myocardial contractility to increase during exercise and to be less during heart failure?
Because in exercise, you want to increase your stroke volume because you want more blood, you want to increase your cardiac output overall. So by increasing the contractility, you're going to increase how the force of contraction to to get blood out of the ventricles.
And what's happening when you're running that increases contractility?
I'm pretty sure like hormonal signals when you're running, like sympathetic stimulation, I guess.
What's sympathetic stimulation?
So like that's like the sympathetic nervous system. So when you are exercising, that whenever you are like exercising, you get like sympathetic stimulation from like the sympathetic nervous system, and that causes.
What does that mean? So we're using sympathetic. What does that mean? What does that mean? What is the sympathetic system?
The sympathetic system is like, so there's two versions, the two parts of the autonomic nervous system. You have the parasympathetic system and the sympathetic system. Sympathetic system is like more the fight or flight system. I think parasympathetic, known as like rest and digest. So when you're exercising, that triggers your fight or flight response, because like evolutionarily, usually when you're exercising, it's because you're running away from like a scary bear or something. And so you want to like trigger your sympathetic nervous system to create all these compensatory mechanisms for you to keep up with that. So one of those.
Yeah, you're pretty going into it. Go.
Yeah, one of those compensatory mechanisms is to increase cardiac contractility to pump more blood. Another one is to increase heart rate to increase cardiac output.
Are being released?
Oh, like adrenaline.
Good, adrenaline. What else?
Yeah, noradrenaline.
Yeah, exactly. So adrenaline's one of the key ones that are responsible for this. Adrenaline, noradrenaline, they're both they're sort of working to increase that. Absolutely. Great. And for heart failure, why would myocardial contractility decrease during heart failure?
Well, in heart failure, you have, I think I said, the hypertrophy of which is just muscle thickening of the ventricles, specifically, and that basically makes them thicker, and like it's harder for them to contract, because I think if you have more muscle, then it's like harder to like fully contract in on the, trying to like do it with my hands, fully contract the and get all of the blood out of the of the ventricles. So you get like probably a smaller like ejection fraction, and then reduced stroke volume, more blood left in the ventricles.
Great, fantastic. And that really is describing, you've sort of seen this next slide, but absolutely. So you can get two main types of heart failure where it can be either dilated or hypertrophic as well. So that's really, really good. I'm going to actually now move on to this. What can you see in this image here?
So in this image, I can see this patient has a lot of bruising in their hand. Okay. The hand's also quite red. So lots of bruising. The veins are quite visible as well.
Tell me more.
Okay. Well, okay, they have a lot of bruising. That could be for a lot of reasons. They could have the like bruising occurs when there's like damage to like the capillaries. I think you just get like a blood pooling under the skin. And so the question says like, well, if we just look at the patient, there's a lot of reasons why someone might have more bruising. The patient looks quite elderly as well. So I think elderly patient,
So if we just go back to just describing the image, not a trick question, what do you see?
An elderly patient with bruising and
really visible
veins in the right hand.
Good. What else do you see?
Oh, the fingers are quite light colored as well.
Yeah.
They're lighter than the skin's color, and the bruising is really dark as well.
Yep. What color is the bruising?
Like dark red.
Yep.
Like purple,
anything else you notice? Yeah.
The fingers are quite light. They're not as dark. Like they're not as like they're like almost like light bluish compared to like the rest of the hand.
Which is what color?
Like whitish.
Yeah. So you've got white,
like whitish purple.
Parameters. What color is this?
That's like a dark red. That's like a normal red, like an orangey red.
Yeah, like a dark orangey browny sort of bronzy color as well.
Yeah.
Why is the color sort of purple here? So you said it's bruising.
It's dark purple because of like bleeding under the skin, which is bruising. So that could be due to like the collapse of like the vessels in that area, which could just be because of some like trauma or damage or something.
Good, fantastic. So that's really, really good in terms of describing images there. So I'm going to actually say that for this one specifically, it was actually a case that this is a bruised hand of someone that's on a blood thinner. Do you know anything about blood thinners?
Okay, so blood thinners, I think one of them, for example, is like warfarin, are used when a patient has blood that's like to stop blood from clotting, because clotting is a high risk factor for things like strokes or like embolisms, and that's all very bad. So you put someone on a blood thinner and it just like I think it reduces the number of clotting factors in blood. Well, they might have different mechanisms, but one of them is to reduce the number of clotting factors in blood, and that will prevent blood from clotting. But I think that can also mean when you get an injury, because you don't have the normal clotting mechanisms, so that could most likely lead to increased chance of bruising because your blood doesn't clot to stop the internal bleeding.
Fantastic.
Or the external bleeding.
Very good, excellent. And you've mentioned one of the key side effects is obviously that it can cause bruising, for example, and that can cause a lot of bleeding. It can cause bleeding anywhere by definition because it increases your risk. So sort of clotting, you can sometimes overcompensate and go the other way.
And bleed.
Where actually exactly where you're bleeding and you're hemorrhaging, and that can be a multitude of ways. That could be from falling onto your head and therefore needing a head scan, for example. It could be because you could be bleeding literally from any place, including the stomach, and that can be causing a lot of problems. So to finish off, my last question for you is, how would you design a clinical trial to examine the efficacy and safety profile of a new blood thinner?
Okay, so I guess if we want to prescribe blood thinners, they're usually for people who have clotting risks. So you would need to get your patient population of probably like people who are at risk of like things like stroke, and who we would prescribe the blood thinners to. And you'd want to, I think the best kind of trial we could do is a randomized control trial where basically
to add you've created a new drug. So it's not an existing one. You've created
completely new drug.
Completely new drug.
So I guess if it's a completely new drug, you probably want to test it in the not in patients first, right? Do you mean like that?
Perhaps.
Well, yeah. Before you go to patients, you'd obviously want to test that it doesn't have any complete side effects. So you might want to test it first off in the lab in like blood samples, see how it affects clotting factors. you might use different samples of blood, and you probably want to use a range of different samples of blood. And then you would want to add your clotting fact, your drug, add your drug, see the effect of see how it clots the blood, how it reduces blood clotting, and then compare that to existing drugs such as like warfarin and see if it is more effective. And then if that is good, I guess
So
you'd want
pause there for a second. So you've mentioned, so you're looking at the mechanism of action of how you want it to work. So whether it's sort of like a warfarin-esque one, or whether what works on a different part of how your blood clots. And we won't dwell too much on that, but yes, that's fine. So you're going to look at making sure it works on different cells. So you're making sure it works to, for example, thin the blood, for example. What's also covered in phase 1 clinical trials, or just in phase 1, what are you also looking at?
Like if it's toxic, how, like if it's cited like toxic to cells, if it has any other unwanted side effects, like completely dangerous. So I guess you'd want to like create that range of like find out what like concentration you want your drug to be at. That what's going to be the safe concentration for like eventual human use. Like how much are we actually going to prescribe?
Safe concentration defined as what?
The amount that we like, the range we prescribe. Like, do you just mean like the range of like amount of drug we prescribe, I guess?
Yeah, to get an effect that causes
to have an effect that also causes a thin but not too thin that you then hemorrhage just randomly.
And not too toxic as well either, in terms of the actual substance as well. So you're doing that in cells, in animal cells, for example. Great, you've passed phase 1. Congratulations. What do you now move on to?
Phase 2, I'm like, for example, like mice studies or something, where you could, for example, like if you could find mice with clotting blood, or you could induce clotting in them and then prescribe some of them the drug and then see the effect and then also compare it to existing drugs that work well, and then compare the effects of reducing the blood clotting. And you want to follow them over a long period of time as well, because you want to see if there's any long-term effects of this drug as well on the mice. And then perhaps you'd want to like test multiple other things to test for potential side effects in humans. And then
so just to pause on that, so great. So you've mentioned about animal models. Tell me a bit more about that. That's really great, but tell me more about that.
An animal model, you could do I think a common animal model is mice. So mice are usually used to test drugs because they're a mammal, so they're somewhat similar to humans despite being a lot smaller. And so with the animal model, you would prescribe them the drug, and then
But you're prescribing healthy mice, are you? Is that your plan?
No, you would induce you would hopefully find unhealthy mice, or you could.
What does induce mean? That's a big word.
You could basically make the mice sick, or you could basically make make the mice increase their chance of blood clotting. So I don't know, give them atherosclerosis or something, make their blood more likely to clot. You could, I think, just make their blood thicker. There might be a way to do that.
Tell me more. These are all great. Let's go to specifics.
Yeah.
How would you create that disease model, right? Because I'm not sure about you, but I don't know many, 10-day-old mice that are having strokes at 10 days. So so how are you designing that as a disease model?
I guess you would basically, you would want them to have a certain level of, could you not just give them clotting could you not just inject them with lots of clotting factors? I don't know if that's.
So you're trying to give them a chemical that increases their clotting risk.
Yeah.
Fine, that's one approach.
So that could be, and then I guess you could also, so you could increase their clotting risk. You could prescribe them a really high fat diet that would cause a general increase in cardiovascular risk.
So you're mentioning a diet in which they're increasing the level of cholesterol, etc.
Or you could do, you could make mice that are genetically altered for cardiovascular risk. So you could, for example, give them hypercholesterolemia gene mutation. So that would make them, or a specific gene mutation to increase clotting risk.
So you're mentioning now genetics. So you're talking about upregulating a gene, for example, for cholesterol. What other gene modifications could you do?
You could modify the clotting factors themselves. You could modify. I don't know if the body has natural unclotting
Modify clotting
factors.
factors which way? To be more effective, less effective?
Upregulated.
Upregulating,
Yeah.
Good.
And then I don't know if the body has natural like blood thinning mechanisms, but you could, if there are, you could downregulate those.
How does that work? Why would that give you your intended results?
Well, because I guess if the body, like, you know, the body's like homeostasis. So when you want to clot, you upregulate the body clots, and then you don't want to be like, clotting your blood. Like when you have a cut, you want to clot your blood, but you don't want to be clotting your blood all the time. So if we stop that like control mechanism to stop clotting, then we have like no like things exist within a range. We eliminate one of the like areas of the range, so then we can just increase the clotting even more because we don't have that like boundary of range. Does that make sense?
Good. So you're talking about basically upregulating the accelerator or down-regulating
the depressor. Yeah.
Exactly.
So you
in
like
both
increase
ways
it
of work.
in one way. Yeah.
Good, because a negative of a negative is a plus. And
Yeah.
that way you'll get the effects. Great, fantastic. That's very good. Okay, great. So congratulations. You've now completed phase 2 trials. What's next?
Phase 3, which is humans, I think. I don't know if we're there yet. I think we are on people. So we've decided our drug is safe for people. We've found a safe range. So now we could do a large randomized control trial on patients to actually see if the drug is effective.
On healthy, unhealthy?
Well, I think actually first, don't you want to test it on healthy people to make sure it doesn't have like, I don't know, because I don't know if giving healthy people a blood clot, a blood thinner, because usually with drugs you want to see if they have any toxic effects on healthy people. But I guess with the drugs such as like a blood thinner, that might not be. So you might skip that stage of trial with this specific drug. Like if it was like a drug for a disease, you'd like a communicable disease, you give it to healthy people. But for this, you probably want to skip that stage and just go straight to the patients who actually need it, because it would have like a more negative effect on the other patients. So you get your patient population who are like high risk for stroke, or who have, like, for example, you could give it to patients with the specific gene mutations, because that would be very specific patient population. And you define your patient population, and then hopefully I think the best way to do it would be like a randomized control trial where you just you give half the patients a placebo drug, and then you give the other half the drug. Or no, I think you probably do normal treatment actually, because placebo drug would be not beneficial.
Are you going to give stroke patients a placebo?
No, don't give the stroke patients. No, you would give them their normal treatment versus the actual treatment, because that would be bad. That would not be good, because you still need to like, you know, consider ethics, and also you need to make sure you're not going to kill your patients in your control group, or like because we want to actually, we're not testing if the drug actually works. We're testing if it's more effective than the existing drugs.
So, but why? So, a few questions. Why? Because there are experiments that you do a placebo, that you do a sugar pill. That is, you know, that is a known thing. So, why in this circumstance are you doing gold standard?
I think because for two reasons would be, one, this drug we're testing if it's more effective than already like shelf drugs that we use. That like, because if like fine, it works, but we still need to then test again if it actually is better.
Yeah.
And then I guess also it would be very noticeable if you prescribed like a placebo drug for this, because the patients would quickly deteriorate, and they may have and this would, like, by giving them a placebo instead of the gold standard, would have negative effects on them.
Yeah. And as you mentioned already, it would be clearly unethical otherwise. Fine. So congratulations. You've done phase 1, 2, 3, and 4. Passed with flying colours. It's much better than what we have existing.
That's great.
What's next?
You'd want to keep following up these patients and do like some long-term studies as well, because if you like put a new drug out there, you still need to follow them up and ensure there's no long-term effects.
So congratulations, you've shown both short and long-term effectiveness. What's next? Get it rolled out within the NHS.
Yeah, you need to get NICE approval for your drug so that they can prescribe on the NHS.
Oh, so NICE approval is one thing for effectiveness, but to get it prescribed on, there's another thing. What is also really important, it's not just effectiveness, it's
like safety.
Covered. That's covered.
Like, I guess.
So it's good and it doesn't have a lot of bad stuff, which is
Yeah.
good. So that's effectiveness. What
Yeah.
else do you want to have as a word perhaps in front of effectiveness that's very important with the NHS, especially
High
nowadays?
effectiveness.
So high effectiveness, you've showed that. What else is
Yeah.
important? Especially given the UK economy. Is it all
Oh,
just about
cheap. You want it to be cheap.
Right, good. So cost effectiveness.
Yeah.
So good. So you can go
Yeah.
to NICE and they what
They
does
don't want your
NICE
drug because
stand
it's
for?
expensive.
Good.
Oh, national something. Oh, I'm not sure.
It's okay.
I know
the
they
national,
approve drugs.
Yeah, exactly. So the National Institute for Health and Care Excellence.
Yeah.
And I sort of think about them as the number crunchers. Why?
Yeah. Because basically they need to decide if a drug is actually worth NHS funding. Because you can
Okay.
make 1,000 great drugs, but if they're really expensive, we're never going to be able to afford them.
Right. So what is the calculation? Some keywords.
So they're gonna, I think they would probably calculate maybe the QALYs of this drug.
Ooh,
like
what's that?
Quality adjusted life years. So basically how effective is this drug at, first off, producing like quality adjusted life years per person. So how many years does this extend this person's life by? Number one would be one thing they probably test for. And then I guess also just like how like effective is it like per patient as well? Like how much does it actually reduce their need to then come back to hospital and use more NHS money? Like how much money are we saving by prescribing them this drug instead of doing the like tertiary complications instead?
Yeah. And what is one quality adjusted life year equal to?
I think it's like one quality. I'm not sure. Like,
so one QALY is equal to 1 year of perfect health.
Okay.
So that's one thing that's really important. So quality adjusted life year is 1 year of perfect health.
Yeah.
And do you know how much roughly it's equivalent to in terms of pounds, in terms of what it's actually assigned as value?
I'm not sure.
No worries. So one quality adjusted life year is equivalent to £20,000 in general. So i.e. if it can give you that, then generally speaking, it's something that can be funded. Exactly. So that's something useful.
So you'd like rate the drug against that then, I guess. Like how much does it cost to prescribe for a year versus a QALY? And if it's cheaper, that's great.
Exactly. So you look at the QALY breakdown versus the gold standard to see is it not only effective, but is it also cheap as well as a medication as well. All right, guys. So that concludes our interview. Sophie, you've been amazing. And predicting one of the questions we'll receive in the comments of like, how did that interview go, etc. Sophie did incredibly well. And I've got to say, like, incredibly well. And she had lots and lots of knowledge. So I would actually say went far and above the standard expected for applicants. But she was absolutely fantastic. So thank you guys so much for watching. I hope you've enjoyed it. Please do share, a like, comment, and subscribe. And we'll see you in the next video. Take care. Bye-bye.